So it is NUR 203 HESI Q&A. I call it the last chance HESI review. It's just literally going a little bit of everything. Now, what I have done is I've gone back to many previous HESIs, looked at the concepts that were on there. Now, I don't get questions. I only get concepts. So I'm trying to figure out what those questions could be and how could I apply the information that I've learned this quarter into what be the answer. Well, I think that if you know me, one of the biggest thing I talk about a lot is nutrition, nutrition. Now, nutrition can be affected by many different ways. It could be that child with irritable bowel syndrome, right? Now, if you have irritable bowel syndrome, you're having a lot of diarrhea, you're not having all the absorption. And what do we know about nutrition? If you don't get nutrition, you're not going to grow, and cognitively, you're not going to be where you should be. So, we know that if they're having, like, for instance, GERD, or they're having IBS and they're losing nutrition because they're throwing it up or they're stooling a lot, what might we see? And always remember, it's always going to be developmental cognition, and it's also going to be that height and weight is not going to be where it should be. If you don't fill the tank with gas, it's just not going to run, it's not going to grow. Now, nutrition can also do things like heal things. Now, we know protein is good for healing, right? One of those things. Osteomyelitis, you got a bone infection. What are some foods that we can do to heal it? Again, nutrition being very important. So fruits, vegetables, whole grains, breads, low fat dairy products, beans, lean meats, and fish. And you can see a lot of this is high protein sort of things in there. Whenever there's a problem with underweight or overweight, always that 24-hour diary or that 3-day diet history gives you a clue into nutrition. Because if they're overweight or underweight, it's what they eat or don't eat. So again, getting that diary. Also, a child who's overweight, are they active? Or are they that person who's always on the iPad playing a game or inside watching movies, whatever? Are they having PE in school? I mean, some schools don't even have that now. Now, one of the things with nutrition could be things like having a disease called celiac disease, which means you can't have gluten, wheat, rye, barley, and oats. And if you have it, it creates havoc and pain in the stomach. And we know celiac disease, there's a loss of a lot of nutrition. So as nurses, not all the time does dietary send you a proper tray. We know that. So what would you remove from the tray? How about if they sent soup with crackers? You can't have the crackers. As simple as removing the crackers, because a kid doesn't know they can't have it. If it's in front of them, they're going to eat it. So remember that. Here's some pictures about thrush, right? That white patches on the tongue. Now, a lot of people think you could just scrape it off. Well, if we can't scrape it off, it's going to need some medication, and that could be nystatin. Another thing with nutrition, and it could be due to foods eaten, or it just could be topical, but diaper rash. Diaper rash is pretty prominent in infants. Remember, if a kid doesn't rest, they're burning calories, they're not going to gain weight. So the infant's not going to sleep. So if you have a kid who's not sleeping at night, one of the things could be a diaper rash. It's simple, right? We only have milk, breast milk or iron fortified formula to 6 months old. At 6 months old, we start introducing foods. And remember, one at a time, 4 to 7 days in between. And why? Well, children do get allergies to foods, and it could be vomiting, diarrhea, abdominal pain, it could be a diaper rash that occurs. Noticing the difference in the child will say, no, we're not going to try that. We'll come back to that again. Now let's look at infants, and let's looking at things that we need to pay attention to. Well, infants are born and they have two fontanelles that are open. The brain is growing and eventually they'll close. The posterior at 2 to 3 months and the anterior about 15 months, it should close. Now, if we're seeing that head circumference increasing, now in the hospital, in the newborn ICU, we measure the head circumference. In the doctor's office, when you go in at that 2-week check, 2 months, 4 months, 6 months, they're checking head circumferences. If it's getting bigger, now we're going to say, oh, what does that fontanelle look like? Because if it's starting to bulge, then we know that it is probably hydrocephalus is occurring. So we could tell by head circumference, also that bulge that's going on. Excuse me. Children, one of the things that they do is they explore the world through their mouths, right? They tend to soothe, fingers, pacifier. And one of the things we have to promote is children who has a condition, whether it be their NPO before surgery or children who can't eat due to a certain condition. Make sure that we give them something, that non-nutritive sucker device, right? That pacifier. Because what does it do? It keeps them calm. It decreases their stress, and it's just normal. And as they get to the point where they can eat, they know how to suck, right? As part of suck, swallow, and breathe is all they do for the first, 6 months, right? So we got to make sure that we keep that promoted. You'll hear a lot of questions about my son did this before this child, and this one does this before that child. And, I think my child's not where they should be, and telling them that all children are different and they're all going to mature at different stages. There are children at 9 months who'll be walking, and there are other children that'll be 15 months and they're just walking. But what would make one more better than the other? As long as they're doing all the other stuff, it is okay, because sometimes it takes longer. But the one who's not walking till 15 months, they're trying to attempt to walk, and that's all you want to see. Now, what about nutrition and that child who is just not gaining weight? They're not gaining weight, or they're intolerant to formulas and whatnot. One of the things that we can do to help that child, sometimes it's their medical condition. It could be a congenital heart defect. They're burning a lot of calories just with their heart, and they are not growing the way they should. And because of that, it's a failure to thrive. Increasing the calories in a formula is as simple as it could be. Enfamil is 20 calories per ounce. When you look at other formulas, we can get it up to 30 calories per ounce. And that's over the counter. They have them there. And even breast milk, we can add fortifier. And that will also help them to get the extra calories with smaller volumes, so they're not burning calories eating. Okay, toddlers, my special toddlers. Me, mine, very egocentric, all about themselves, right? Getting on their level. Sometimes it's through play. Play helps. I've said I've always had stickers. I've always had something to distract them. I'd always sit down below them and, very easily go up. You can't walk in with a blood pressure machine and expect to take a blood pressure right away. It's not going to happen. Sometimes you're going to have, let's say you have a little girl who brought in their doll. Well, let's take the blood pressure on your doll first. Here, help me push the button. Using play really helps. Preschoolers. Preschoolers should be talking at least 4-word sentences, okay? When you are a 1-year-old, maybe it's one word, mommy, daddy, milk, those type of things. But remember, as they get older, it should be more and more words. Now, autism. Autism is something that we do not assess till about 2 to 3 years old. And there are all sorts of questionnaires that could be filled out that could pinpoint it. So we do have them, if we're going to be working in that area. The big thing is repetitive behaviors. We know they don't like touch, they don't like noise, they don't like a lot of people, and they don't like bright lights. And they're not going to look you in the eyes, but it's the repetitive behaviors, doing something over and over and over again. Now, school age children. One of these children, the school age children, one of the things we start looking at is, their height always. And of course, school age, you start seeing there are some kids shorter than the other. Now, is it due to growth hormones, or is it due that's the size of the family? So don't always assume we need to start growth hormones on these children. You need to go now. Go. So anyway, you need to look at the height of the children of the other families. And if they're all 5 foot tall, the child's not going to be more than that. So you can't make it more than what's possible. When you have children in the hospital, and you have children at home, it's very difficult for both sides. I mean, we're lucky today with FaceTime. Before FaceTime, what did I do as a nurse? Well, I would send home colored pictures from the hospital. I would encourage the parents to send them in from the other kids. I would do all different things for them because they're scared. But also, remember, kids at home might feel neglected, right? Because mommy and daddy are always at the hospital. So these are things that we should point out to parents. Now, school age children at that age, talking about tonsils, adenoidectomies, and putting ear tubes in, that's a very commonplace at that young school age children. Now, if a child's going to be coming in, and whether it's outpatient or going to be admitted, one of the things we need to understand is, have they been in a hospital before, and how did they react to it, right? Very important. Now, you think the child who's never been there is going to have more fear. No, it's the child who's been in and out of that hospital who's going to have more fear of the hospital because maybe they had a bad experience. So understanding the child and if they've been in and the way they act will help us as nurses take care of them. Now, adolescence is those chronic diseases, like cystic fibrosis, cardiac diseases. They're in and out of the hospital. One of the things adolescents need is all about their friends, their buddies in them, as I call them, and making sure that they have time to spend it with their friends. It might be going to, a quiet room with their friends because they can't go to the room if they're in double bunked with another child. But make sure that you give them time to be with their friends. Their friends are very important now. I mean, this is a time they want only their friends. Yeah, they want mom around during hospitalizations, but they want to keep in contact. Now, Tanner's stages of development, I've seen examine questions on the HESI regarding this. Which stage? And if you look at the stages, number 1 is nothing. They've flat chested, nothing's happened to their genitalia yet. And as we go up stages, you're going to see the the areolar is enlarging. And then you're starting with contours and you get into the real female, the mature. So figuring out what stage, just think about, this starts at nothing and 5 is that mature. So it's easier to pick out an answer with that. Now, adolescents are getting very sexually curious, right? They're finding out their identity. And, Freud says it's all about phallic now. It's all about, sexual beings. And adolescents will ask you as a nurse about oral contraceptives. Now, we don't have to talk in front of the parents regarding this, but you don't give your opinion. All you can do is give oral and written information and counsel them on the benefits and risks. Okay? It's not your personal opinions here. Now, Piaget. Piaget is that thing about cognitive development. Just think about it. It's how an infant figure things out. Now, if you're figuring things out, we'll go from the very beginning. So we start out with that reflex grasp and we grasp that rattle, right? And all of a sudden they move that and they hear a noise. I figured something else. Ooh, now they get to be that voluntary grasp and they shake it themselves because they've learned. Then it goes further. Then they put the rattle in the mouth, right? They explore the world in their mouth. So these are things you figure out what's cognitive. It goes from figuring out a rattle can rattle and figure out how to run mommy if we're throwing things on the floor when we're eating because we want them back, up to adolescents who can figure their way how to get off a punishment and go out with their friends on Friday night. They know what mommy and dad wants. They're very abstract thinking by then. So we go from just figuring out the simple to figuring out to get what they want. And in infants, we talk about object permanence. So, that little kid, he took that little toy, it fell underneath the blanket, and now the kid is still looking for it. And that is that object permanence. Once they know it's there, they know that we're going to go back and they're going to find it again. Now, Erickson, the 3 ones that are always tested on is infants, school age, and adolescents. So let's just quick go over them. Infant, trust versus mistrust. And the trust is I cry, somebody's coming to get me, whether I'm hungry, dirty, gassy, or just want you. Their needs are met. That mistrust is those family environments where they don't get the child right away and they cry and nobody comes. And actually, eventually, these children stop crying because they know nobody's coming for them. It happens. And that could be in those homes where there's drugs, there's abuse, many different things can cause that. Now, school age. School age talks about industry versus inferiority. So I figured out how to work with that word industry and make you understand this is what a kid does well. Industry is their factory, it's their building, it's what they make, it's their product. That is their industry. Those are things they do well, whether it's baking, playing a piano, running, jumping. It could be anything they do well, okay? Now, one of the things about this and the concept they want you to understand is, let's say you have a school age child in the hospital for an extended period of time for whatever reason. These kids still need to be challenged. So what would you do? Well, most pediatric centers have child life in them now, and they have all sorts of things that we can give our children to stimulate them. Now, what would be something good for a school age child? Well, if it's a 6-year-old, you might get a 20-piece puzzle, and it might take a little time to get it together, but with a little effort, they will accomplish the task. So when you're giving them a task, make sure it can be accomplished. Don't give a 6-year-old child a 250-piece puzzle and expect them to do it without throwing the pieces all over the room and get frustrated, right? You've got to do it on their abilities. Now, an 11-year-old, sure, a 250-word puzzle on a cognitively normal child, absolutely. And it does. It gives them a sense of achievement and accomplishment. With your adolescents, remember, it's all about identity. Who am I? Do I like girls? Do I like boys? Do I like both? Who do I want to be? Do I like the band group, the sports group, the rockers? Who am I? So figuring out who am I? Do I like my short hair, my long hair? Am I too skinny? Am I too fat? I mean, all of this stuff. Now, adolescents tend to not, most of them, not want to talk in front of their parents, right? Now, my last 10 years as a nurse in the hospital, I worked in a pediatric trauma center in an ER. And I can't tell you how many times where, children would come, especially girls with frequent urinary tract infections. I'm telling you, that's probably the most common that I would see on these girls coming in. So the parents, we'd ask them to leave the room, and I'd say, "So, why do you think you're getting these urinary tract infections?" And then I'll say, "Are you sexually active? Because it can affect it." And it's, I've built up that rapport. I've already asked about what they want to be, commenting on the sneakers they're wearing or the sports jersey they're wearing. So now I've got a rapport with them. Because remember, I'm an adult too. How are they going to speak to me? Well, I built up that confidence. Send the parents out, and those adolescents, I'm telling you, sit down to listen because they're going to tell you things that will shock you. And it's just and they're looking for your response. Have the parents leave when this all goes on, and you don't have to tell the parents what they have said unless it's something that will harm themselves or others, okay? All right, let's go through some of the systems now. Hematology. I mean, we've learned everything what hemophilia is, right? We know it's a bleeding disorder. There's a clot. One of the factors is missing. Your blood doesn't clot and you bleed, 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 bleed. Our biggest concern with the bleeding would be into a joint. And the reason why that is blood in a joint is caustic and it will destroy the joint sac. And eventually that child is going to be crippled and end up in a wheelchair. So how do we protect children? Now, not all children are diagnosed at birth. It could be later on. And it could be because of frequent nosebleeds. I've seen a lot of bleeding diagnoses diagnosed when they come in for their third nosebleed. And we're like, all right, let's draw some lab works here. So now you've got that toddler. Well, think about a toddler. They're wobbly and they're running and they're falling and they're bouncing into everything, right? So what would be something that we would teach? Well, it'd be all about safety, right? Those home environments, I mean, I just think of the coffee tables and the sharp edges, and I think of toddlers running by and getting cut. How about if we pad the furniture or get a different furniture or remove the furniture? You've got to protect and make that house safe. It's just like covering electrical outlets, right? And putting stuff that's for cleaning things in a locked cabinet or medication. It's the same thing. Safety, safety, safety. You're not going to stop them from running. That's not what a toddler does. They're going to do what they want. So you've got to think outside the box there. Now, I've mentioned a nosebleed, epistaxis. And what's the treatment? Well, we teach them a thumb and a forefinger, pinch it, and we lean forward. We don't lean back. And the reason why forward is we want the blood to come out the mouth. We don't want them to swallow it. If they swallow it, enough blood, guess what's going to happen? They're going to vomit, and we don't want that, okay? So thumb, forefinger, hold it 10 minutes. If after 10 minutes still bleeding, they need to seek medical care. It might need further intervention, okay? So a lot of times they come in with that nosebleeds again, and we're going to do lab works. What do? Well, we'll do a simple CBC, and we'll do bleeding studies, that PTT and a PT. That just looks at bleeding and it looks at platelets, because platelets are part of the stuff that clots the blood so that you don't bleed to death, right? So platelet counts are low. Now, does that mean that this child is idiopathic thrombocytopenia purpura, ITP? Not necessarily. It also could mean a child who's in overwhelming sepsis, burning platelets, and platelet counts are low. You see it a lot with leukemia. Any child on chemotherapy, you'll see it because it burns up your hemoglobin, your hematocrit, your red blood cells, your platelets, but platelet counts low. Always remember, for whatever reason, put them on bleeding precautions. These children will have ecchymotic areas, will have petechiae, check their soft toothbrushes, their gums are going to bleed, check their stool, check their urine, and if the adolescent wants to shave their leg with low platelets, you tell them no, because they're going to cut their leg, right? So bleeding precautions. What other things are bleeding precautions? Well, if they're in the hospital, platelets are low, you're going to be checking those CBCs that they're drawing, seeing where the platelets are. The second thing we're going to be doing is no IM injections, no injections, if at all possible, because you put an injection in, guess what? They're going to bleed, they're going to bruise. So we try to decrease the amount of things that make these children bruise and bleeds, okay? Sickle cell disease. The big thing with sickle cell disease is that the vessels get small. And then when they get small, when they bifurcate, these cells clump up. They can't get down. They start up top, but they can't go down. So what do we do to treat sickle cell disease? I mean, it hurts. It's horrible. But if you treat for pain, you're not treating the cause. You're only treating the symptom. The cause is narrow vessels. How do you open up a blood vessel? We're going to give fluids and we're going to give heat. Dilate it, get it open. This also goes with dressing warm in cold weather, right? We don't think of that, do we? But keep them warm, because what happens in cold weather? Everything constricts. They also say before you get on airplanes, make sure you're hydrated, because the pressure in the cabin squirts down, squeezes down on those blood vessels, causing them to get thinner too. Now, acute lymphocytic leukemia. This child does not have a white blood cell. She's completely open to sepsis. This child is so immunosuppressed, and these children need really special treatment. If they come into the hospital, they don't need to be running through lab and x-ray to go up to the room. No, they don't need all that exposure. Bring them right up to the room and do it in the room, because you're exposing them to things that they unnecessarily, they don't need to. So always wash hands, wash hands, wash hands, right? Prevent infections, and they should be in their own room. Even other children with ALL, we still try to keep them in their own room, because everybody has their own type of germs, right? And then iron deficient anemia, most common of all anemia in children. So one of the things with iron deficient anemia, we know they're tired, right? There's no red blood cells, there's no oxygen going to the body. The child's tired because it doesn't have the gas, the energy, the oxygen to move. So we can give a diet high in iron. Those green leafy vegetables are great things. Liver, everybody loves liver, right? But it's really high in iron. Actually, I love liver. I make it really well, but besides the point. The other thing is we'll give them medication. We'll give them iron. What do we know about iron? Don't give it after they eat. Before they eat, they should get it, and never with milk. And orange juice helps it dissolve. And why is that? Well, iron is metabolized in the stomach with the stomach acid. You give orange juice, another acid, now it metabolizes, it gets into the body, and it becomes useful for the body to have the iron it needs, okay? Now, orthopedics, bones, JIA. Well, school-age children are those who likes to please people, right? They're people pleasers. They don't want to do wrong. They don't want to be punished, but they love rewards, right? Now, JIA is, the bones, the joints get inflamed. There's all symptoms with it. It's that muscle weakness in the morning and stiff. It's the joints get swollen. It's the uveitis where the eyes get all reddened and can affect your vision. Um, One of the things with JIA is these children need to keep their body moving. And I happen to have, RA. And one of the things that keeps me going is swimming. Swimming is very non-threatening to the body, and it moves my joint, and I feel weightless. It's a great thing for a child with arthritis. All right, now you have a kid fell off a monkey bar and it's holding the arm. Oh, I hurt, I hurt, I hurt. What's the first thing you need to check? Well, priority, there's a bone broke, there's swelling going on. Is the blood flow been restricted? So if it's in the elbow, you're going to go distally. Do you have good capillary refills? Do you have pulses? Right? Very important. We're checking all the P's here, aren't we? It's part of that and the casting thing also. Scoliosis, S-shaped curvature of the spine. Now, scoliosis can be treated with a harness, right? That where they wear it, this brace for 23 hours a day. Nothing, no lotions or powder underneath, just a nice cotton t-shirt, they say is great. And exercise, and sometimes that works. If it is a percentage greater than 45%, are going to do surgery. And if you look at that picture on the right, that's the Harrington rod they put in, and it attaches to the spinal column to try to straighten it up because it's curved. And when that curves, it's making that lung cavity smaller so they can't breathe. So that's why they do the surgery, to protect the lungs. These children are log rolled because they have this big new metal rod, which can go from the top of the spine down to the bottom. It's quite long, okay? So log rolling is what they need. And then osteomyelitis, an infection of the bone. Children tend to walk outside. I know my little grandson, he never goes outside with shoes on. You have to fight with him. And what happens all of a sudden, his big toe turns red and it's painful, and now he's running a fever. Oh, this is something that could cause osteomyelitis. Now, most children, just with the washing, cleaning, etc., when they see that little puncture, they'll be okay. But if it's a kid who's having chronic infections all the time, that's telling you their immune system isn't really where it should be. And that child we need to really pay attention to. So we'll treat it with what? The IV antibiotics. And we know that these children need to have a good diet when they are healing from this. Again, protein is a good thing, right? High protein is good for that. Now, everybody's nemesis is cardiac. It's like, oh my goodness, cardiac. Well, cardiac, just think about it as a hose that gets kinks in it. And if the hose gets kinked, it's always a backwards failure. Kawasaki. When a child comes in with this systemic vascularitis, inflammation of the vessels, We know that we're worried about aneurysms in the coronary arteries. We're worried about that vascularitis, that inflammation, and the release of little microembolus going into the body. So, priority procedure is an echocardiogram. Let's check those vessels. What medications do we give? Well, we give the intravenous immunoglobulins and high-dose aspirin. This is one of those that we give aspirin to. Why aspirin? Well, it thins the blood and it decreases clots, which is what you want to do. You don't want the heart, to have this big clot go up and occlude it, and they'll have young children having heart attacks because of that. Indomethacin, prostaglandins. One opens, one closes, right? Indomethacin is used to close the duct that's open at birth, called the patent ductus arteriosus. Indomethacin is a medication. It's an NSAID, actually, and it's given intravenously. And it's given in 3 doses, and it's given to close the duct without surgery. There is prostaglandins that actually mommy produces, this hormone that keeps that duct open while the baby is, intrautero. When the baby's born, it usually stops producing it. Not all babies stop having that prostaglandin. Sometimes we have to give indomethacin, which stops the production of prostaglandins, and it closes. Now, I used to love giving this stuff. You give indomethacin for a PDA, and we know there's this big washing machine murmur that goes on, and it's going to be decreasing. You're going to listen, and it's going to decrease. And remember that wide pulse pressure, 60/15 at birth? Well, it's going to go back to where it should be, 60/40. And you watch that bottom number come up, and you can watch it. Congenital heart disease. When you know something's going on, that means deteriorating condition. The heart is congenital heart disease. There's something wrong, and it doesn't beat the way it should. Blood's not flowing the way it should. You don't oxygenate the way they should. Now, all of a sudden, you're seeing deteriorating. Well, you're going to see that kid tire out during feeds, right? You're going to see the respiratory rate go up. Now, when you start seeing these things going on, first thing, I'm going to listen to the lungs. Most likely the heart is failing. That heart's just not doing what it should do. And when that happens and you hear that fluid, now we're going to take your weight, and you're going to probably see that child has a sudden weight gain because that extra fluid that's there, and the heart's not working. You're going to see the blood pressure starting to decrease. And it's that decreasing blood pressure which makes you call the doctor. Cardiac catheterizations are done when we know there's a congenital problem in the heart, and our biggest risk will always be bleeding. Especially a lot of these are, brand new neonates. These are within the first week of life we're doing cardiac caths. And it's a big vessel in the femoral artery and femoral vein. And when we pull those catheters out, apply pressure, get a clot, and the movement sometimes coming back to the rooms or moving them from stretcher to bed, it can dislodge. Bleeding is the biggest thing. Now, one of the medications used the most in children, lower and strengthen the force of contraction, is digoxin. Well, what do we do when we give digoxin to an adult? It's the same thing here. It's the difference of kids versus adults. Well, you're going to check a heart rate. You need to know what normal heart rates are on different ages children. If you have a newborn or an infant, first year of life, and the heart rate is 80, that is low. Now, an adult is okay, but on an infant, it is, way too low. What are we going to do? Well, you've checked the heart rate. Well, what was the last potassium level that was drawn? What was the last digoxin level that was done? To check on that. Sometimes with infants, the only thing that you will see, or this is an infant that's gone home, and the mother calls up and says, I was just about to give my baby the digoxin, but the baby is vomiting. What should I do? That could be the only sign you see. You would hold the digoxin, you would tell the doctor they're going to have to get a blood level drawn to rule out dig toxicity. You're not going to give a vomiting child a dose again because they vomited it. No, you hold it and you're going to be safe with it. Rheumatic fever is caused by a strep infection. And remember, everything will come back except for the heart valve if it's damaged. Now, urinary. Well, most common thing in the urinary system in children is urinary tract infections. One of the first things that we may see is enuresis or nocturia or wetting the bed at night when they're previously potty trained. If we see that, then we go looking. Is there reddening, itching, frequency, urgency? We'll check for that. All we do is what? Increase some fluids on these children, making sure they wipe front to back. No bubble baths for little girls because they can't sit in that dirty bath water because that can cause it. And a nice white cotton underwear is actually what they tell you to do. Cryptorchidism, little baby boys and their testicles. First visit, what does the neonatologist, the pediatrician do? They check the joint for the hips, and then they check their testicles. Are they down there? Well, remember, if you have an infant open, exposed in a cold room, males, when they're cold, their testicles suck in. You're not going to get a good report. Make sure they're in a warm room because they'll hang a lot easier, okay? Another thing, if the doctor or, examining or you're examining and you don't see a testicle, I would ask, have you seen this testicle before? It could be one of those intermittent in and out things that will make a difference in treatment too. Now, many of the times, especially with these big problems with staph infections, and polynephritis, it could be anything, an infection that this child needs to be placed on an aminoglucoside like vancomycin. Vancomycin, all the sin drugs, as I call it, gentamicin, amikacin, vancomycin, all of these things, there are big red flags that we need to teach our parents. Number one, especially if they're going to go home on a PICC line with them, and then they do that a lot today, making sure that they get to their lab appointments for their peak and trough levels. Now, let's say they've been in a hospital this whole time, they just finished up the course, and now they're sending this child home. Well, the one thing that must be monitored is the side effects of those aminoglucosides. The side effect of those vancomycin is hearing loss, and it damages the kidney. So to make sure it has not turned into hearing loss side effect or damaging the kidneys, you're going to see decreased diapers, right? Decreased urinary output. Something we need to have the parents watching, for several weeks after these big long courses of that type of medicine. Now, nephrotic syndrome, this child is not kidney failure. The kidneys work, they're great, but it just says protein, yuck, I don't like you, and it spits it out. And you see all the protein come out in the urine. Well, what happens is The fluid balance in the body just starts to put fluid interstitial. So all the interstitial tissue, even in the cheeks, the tongue, all get swollen up and they just stop urinating, right? They're not urinating, they're urinating protein, but they're getting all of this swelling. Now, one of the treatments is they're going to give IV albumin. IV albumin is another word for protein. Albumin is protein. If you replace the protein into the blood system, it's going to pull out that fluid again. Because before you had none, well, now it's starting to, compensate. It now pulls it out. And how do you know that the albumin has worked after you give it? Well, it's pulled out the fluid, and you're going to see the edema is going to be decreasing. Makes sense, doesn't it? Now, hypospadias, epispadias. Well, the one thing about this condition is hypospadias, instead the urethra doesn't come out in the meatus on the tip of the penis. The hypospadia is somewhere on the bottom, and it could be anywhere on the bottom. It's just not on the tip. And epispadias is on top somewhere. It's just not on the tip. And initially it's okay, but there can be no circumcision done on these children. This might affect the Jewish faith, right? Don't they do a brisk and they like to, it's one of these big formal things they do. They need the foreskin to do the surgery. So that could be a problem with some cultures, all right? What they do is they fillet the penis, as you can see that middle one, they open it up and they make a canal to the tip of the penis, and then they close it up and they use the foreskin for plastic closure. They put in a catheter that will hold open that lumen, and it's there for like 7 to 10 days, all right? Now, we will do this usually before they're potty trained. We like to get this done so they'll pee out the right place, right? Because how are you going to teach them to urinate in the toilet if they're peeing up or down in the wrong place? But that tube is kept in there, and usually it's, still in diapers. So make sure it's inside the diaper. We don't touch it, we don't flush it, we don't roll it, we don't put ointment on it, we do nothing. We just keep that inside a diaper so you don't get urine everywhere. It's the only thing we do with that. And then the nephrologist takes it out. A Wilms tumor, it's a kidney tumor. The big thing about a kidney tumor, it's extremely, it's cancerous and it's fragile. We say, do not palpate abdomen, right? Because we don't want to touch and make little pieces float away and metastasize in the peritoneum. There is no pre-op biopsy of this. Many cancers are, we don't. And why? Well, if you put a needle into that encapsulated tumor, what have you done? You've released metastasis. So we don't do biopsies on those either. Chronic kidney disease, big thing, concern in children is osteodystrophy, which is the bones malformed, not growing the way that they should, right? So one of the things that we're going to give is calcium and vitamin D to help that. Also, chronic kidney disease, not producing red blood cells the way it should, and we will be getting erythropoietin injections to help red blood cells be formed. It's basically makes the body do what it can do and decreases the amount of blood transfusions that have to be done. Glomerulonephritis, the big cause of strep. You stop urinating, you get hypertensive. Again, remember, anything that we're concerned about, fluid balance is always intake, output, daily weights. It's all the times the way that we regulate it. And what do you do with testicular pain? Well, Testicular pain is an emergency. It's a high-level emergency in an ER because it gets torsion, it can get twist, and it can stop that testicle from getting blood supply and die. So this is something that needs to be reported immediately. Okay, let's go into respiratory. Well, epiglottitis is croup that we didn't treat, and now the epiglottis is now big and swollen. So the epiglottis covers the trachea and it's swollen, and air can't get into the lungs. So you have an inspiratory stridor. And our biggest concern is, can this child breathe? So what equipment is needed there at that bedside? Well, an intubation cart, right? And a tracheostomy tray. Whatever has to be done to get that airway open, because without an airway, nothing else matters, right? You're going to see a child inspiratory stridor. They're going to be drooling. They're going to be bent over in a tripod position, a big garbled voice. These children get air hungry and restless, and we need to, treat them as quick as possible. Racemic epi and steroids, and to get them turned around. Asthma, one of the things that's seen children with asthma come into the ER because they're not using their meter dose inhalers properly or the way that they should. Always make sure that they have a spacer, young kids, like that little picture in that bottom, that good old tube, and then they're going to be getting the proper dose. Remember I said croup, if not treated correctly, or sometimes even treated, still can turn into epiglottitis. So what is our concern? Well, if they stop being able to swallow secretions, they need to get to treatment immediately. That's epiglottitis, isn't it? Croup turns into epiglottitis. A croup that now you can't swallow, it's really highly likely it's epiglottitis now. So we need to teach the parents. If they can't swallow, go to the ER now. And one of the things they say is if the croup was severe enough to have had a racemic epi aerosol at the ER, that's a child that's more likely to get those really severe effects, okay? RSV, respiratory syncytial virus. We should suction the nose. It's a lot of mucus and a little fever, causes a lot of respiratory distress, right? It's an upper respiratory. It is a virus, but swallowing, and breathing on an infant is a lot of work. And there are children, congenital heart defects, cystic fibrosis, children that already premature children. These children already have a hard enough time sucking, swallowing, and breathing, right? Well, if they're already there, let's just suction their nose out a little bit to try to help them. Don't overdo it. Those children that are already, compromised, they should be getting a Synagis or a palivizumab vaccine monthly from winter to early spring. Very important. And it's once a month, only for the first year. And then after that, the symptoms aren't as bad. And actually, you and me, it's a common cold. I mean, there is some bad RSV out there now, but it's really a big, bad cold. When they're being admitted, or any upper respiratory, child is coming in for admission, always remember, upper respiratory, you're placing them in a semi-private room. Where do you place them with the best way? Well, make sure we know the immunization status on all the children. It could be pertussis, it could be something else. So always know the immunized children together, and the ones that are not should be in a room alone until we figure out what's going on with them. Respiratory distress in infants. What makes them unique? And it's the symptoms that you see. In respiratory distress, we know there's tachypnea, and there's retractions. In infants, nasal flaring, and then there's a grunt at the end of a breath. It's like a, and then there's that head bobbing too that goes on. But flaring and grunting are the two big infant things that you'll see. Cystic fibrosis. Well, why are we giving chest CPT and why enzymes? Well, cystic fibrosis affects lungs and the digestive process in the small intestines. So it's two places we got to worry about. So we give chest CPT because we'll give an aerosol first of a dilator, like albuterol, open up the chest, give aggressive CPT and postural drainage and get all that mucus out. Why do we give enzymes? Well, they're not digesting the way that they should. They're not getting the fats digested, and the pancreas isn't working the way it should. So we're going to give them an enzyme before they eat, and it will help with that digestion of some of those nutrients. At birth, this is a child that's not going to move its bowel the first 24 to 36 hours. And one of the things that, that I would tell a parent, I wouldn't do it myself, but if you lick the skin on an infant that suspected cystic fibrosis, it would taste like salt coming out. And what do they do to diagnose it? It's called a sweat chloride test. Just measures the salt on the skin, basically. Albuterol is always your rescue because it's a bronchodilator. Now, GI. Well, diarrhea is always a concern. And one of the things we don't think about is all that extra acid and alkaline coming out on that, into the diaper, especially young kids, even older kids. It's causing the area to be excoriated and burn. This kid's not going to sleep well at night. Something to pay attention to and something to look for when we're doing an assessment. Child comes in with abdominal pain. What do you need to know? Well, where is that pain? When did it start? What does it feel like, right? Is it a right lower quadrant pain or is it an umbilical pain? Makes a difference in the treatment. Now, sometimes we have to do abdominal surgery. A lot of times it's some intestinal obstruction. We have to go in there and manipulate the intestines like crazy, right? Well, one of the side effects of this manipulation of the intestines can cause a paralytic ileus, which means the intestines stop. They just stop. They come paralyzed. They don't move. And what does that feel like? Well, it is severe colicky abdominal pain. Because stuff can't go down, you start nausea and the vomiting. And stuff can't go down, the belly gets bigger, bigger, bigger. So it's something that can happen status post-abdominal surgery, something to look for. Pyloric stenosis, this is projectile across the room vomiting, right? We have the one that just dribbles, and that's the GERD. Happens in all age, infants and adults, children, everybody. Pyloric stenosis is that 3 weeks to about 3 months. And that valve gets thickened and hard, and it doesn't allow anything to go into the intestines. And it fills up the stomach when they eat, and they feel good, these infants, and all of a sudden, explosive across the room. I'm talking 10, 15 feet across the room. It's actually quite impressive that this little tiny infant can do that. Now, they're hungry. They're irritable. They're not getting nutrition. So they're insatiable. They want to eat. But if you allow them to eat, guess what's going to happen? They're just going to vomit again. So you will feel in around the mid-abdomen, a little bit to the right, maybe, is this olive, or I even call it a marble. It's this hard, and you can feel it. So if they tell me he's a vomiting projectile across the room, my hand goes up underneath that xiphoid process, and I can feel that little hard thing. I know what it is. And I tell them, please don't feed the baby anymore. Intus is, now let's just go right to GERD because that's very close. GERD is spit up on infants. You know, we'll thicken the formula for them. It'll hold it down. How do we know that that works? Well, they're not vomiting and spitting up as much. It's as simple as that. Now, older kids, they're going to be having a cough because of many aspirations, and they're going to have heartburn, and it hurts. So how do we treat the older child with GERD? Well, it's going to be a bland. I mean, if you had so many things to eat, I mean, cookies are okay, but pizza, chocolate, anything spicy, greasy, is something that will not agree with these children. But a cookie, sure, why not? What if you have a child at any age? Usually we talk about this a lot of time, it's infant. They go home, they're okay, and all of a sudden you start seeing they're turning a little bit golden. Their sclera is turning yellow, and now their urine is turned darker, a tea color. Then you see that their stools have a very pale color. They're not as yellow and browny as they should look. Always think of biliary atresia. Biliary atresia is no bile being secreted to digest fat. So that's why the stools are pale. And atresia means no opening from the liver to the common bile duct. So where does that extra bile go? It goes systemic. Therefore, jaundice, sclera, and the urine tea colored. Now, neuro. A lot of times you'll get kids saying, I feel ringing in my ears. And we can just say, oh, it's probably you have those earphones on all the time, listening to music, whatever, whatever. But the first thing as a nurse is to look inside. I've seen things like roaches, I've seen ants, I have seen actually a bumblebee in the ear. So it can happen. So check there first and then go from there. And you're going to say, how did we treat those things with the bugs, right? We put mineral oil in the ear and it floated it out. That's how you get those out without harming the ear, and it smothers the insect, and then we can get it out easy. Meningitis, always remember, whether viral, bacterial, first thing we're going to do is prepare for a lumbar puncture. Now, what's the first thing we're going to do to protect us? Droplet isolation until we rule out viral or bacterial meningitis, okay? Safety in seizures all the time. Seizures, tonic-clonic, we usually refer to. They're moving up and down all over the place. Always know, protect from safety with toys in the bed, put the bed flat, remove the pillow, pad the side rails, and then turn them to the side and have suction, just to keep the area around where they're breathing. If they're vomiting, suction that vomit away, not to stick it in their mouth, okay? Safety, safety, seizures, and we need to teach parents about that. Febrile seizures are scary, and parents always want to know after the first one, does this mean my baby has epilepsy? And the answer is, it doesn't appear to be. This is one seizure, and usually febrile seizures, they will outgrow. If it becomes more frequent, we might consider it that, but at this point, no. It's not going to mean that they have epilepsy. Myelomeningocele is when the meninges and spinal cords are ripped up and out and outside the body. What's our big concern? It's nerve damage in the lower extremities because it rips it up and pulls it up and out to the back like that. And you look at that, our biggest concern is infection, putting a nice wet sterile dressing on it. And look at the skin integrity. Now, that's initial. But until we get prepared for surgery, these children have poor feeling on their lower extremities, which include bladder function and also their stools. They don't feel if they have to move their bowels. We always put these children immediately on latex allergies, okay? Latex allergies could be just rashing and it could be anaphylaxis. Neuro, biggest tested neuro, Duchenne muscular dystrophy. We know it's boys. Usually we see them, we diagnose between ages 3 and 7. And we diagnose them by measuring muscle strength. And we do that by doing an EMG, an electromyography, where they take a little type of electrical current and squirt it into that child. It goes, and we watch how quickly and how strong those muscles contract, okay? Now, when they're done, they feel like they've run a marathon. Prepare the family and the child. They're going to want some Tylenol or ibuprofen when they come back because it does hurt. Eye injuries, when we don't know if something's sticking in there that could cause harm, patch both eyes, get them to medical care. That's the treatment. Nystagmus, remember an eye exam and the 6 cardinal positions of gaze, all right? Nystagmus, the eyes are just moving. Hydrocephalus, we have extra fluid on the brain, and we're going to put in a ventricular peritoneal shunt for that, right? Now, what do we see with hydrocephalus initially? Well, we're going to see that bulging fontanelle, right? Increase in head circumference, like I said before. And one of the things about growing into a VP shunt and getting older, they disconnect a lot. And the 2 big symptoms are headache and vomiting. And they'll do an X-ray study to look at the shunt, and a lot of times they go to surgery and connect it. Now, if they came in there vomiting and headache, get their shunt revision, how do you know that the surgery worked? Well, they're not with a headache anymore and they're not vomiting. Endocrine. Well, one of the things I always say, these children get height and weight on every visit, no matter where they go. Adults, they don't care anymore, but in children, they do, because there's so many things that it can affect children's growth and development. And one of them is hyperpituitarism. And we measure and we detect that by height and weight every visit. Remember, the parathyroid has nothing to do with the thyroid. Parathyroid is all about calcium regulation, and that has to do with muscle strength or weakness. Hypoparathyroidism, the muscles are weak, okay? Hyper, they're in big contractions. Diabetic ketoacidosis, well, one of the things is we're going to be giving fluids and we're going to be giving regular insulin to correct it quickly, right? And we'll be monitoring those blood sugars. Now, children in diabetes, they can have a normal life with it, but making sure that they check blood sugars before they be active in sports, that they eat not just sugar, but protein, which is lasts longer. So that, and then making sure that they're checking it if they're playing a real long game, right? So it's just being very careful with blood sugars and having those snacks on hand if they do need them. Diabetes, they should be rotating injections around. And the signs and symptoms. sweating, shaking, headache, nausea, right? And what are the thyroid hormones? T3, T4, TSH. There was a question a couple years ago about breastfeeding and formulas and thyroid hormones. Just remember, if TSH is high, the T4 is low. And if the T4 is high, the TSH is low. So it's like opposite from each other. It's just the way those hormones work. If you have a child, especially the adolescents, and they're overweight, remember one of the things we're concerned about is diabetes, right? So if we see them urinating, if we see them, thirsty and urinating, one of the things that we would suspect is maybe a urinary tract infection with all that urinating, but it also could be diabetes. So making sure that we test for all like electrolytes with the urinating, checking the urine just to see if there's any infection. And of course, a hemoglobin A1C, ruling out diabetes. Common kid disease and pentago. And pentago is extremely infection. It's a staph infection. Christian had it on the back of his knee and it spread like wildfire so quickly. And thank God he was with me because I knew exactly what it was when I saw it. Very, very contagious. So making sure you use hands, using gloves for you and washing hands. Do not pop that fluid. It spreads that infection. They will give you oral antibiotics and they'll give you topically to put it on there. Conjunctivitis, we know like that little picture, that's a normal looking conjunctivitis. We clear, from the inside out, just warm water. Remember for giving ointments, making sure that it's going to blur vision. Even with adults, if you don't tell them, oh my God, I can't see, oh my God, get this out of me. Oh my God, this is hurting me, right? Just knowing that it's going to be blurring for a second. Once it warms up in there, you're going to see fine again. It's just preparing them. So you have a child that had a tick removed and now they're with a fever. What are you going to do? Well, this is when you get to the doctor. Now we're worried about all the things that ticks can do, right? I mean, even if you had a child who was next to another child who has had a tick, what would you do? Well, you're just going to do a visual inspection head to toe, making sure that your child doesn't have any ticks. And kid gets a wound, steps on that rusty nail, the old tetanus, right? So those children come in, you see them all the time doing something and cutting the bottom of their feet or their hand with something. Well, always check the immunization status. And don't forget that we are going to clean that area with soap and water and put an antibiotic ointment on. And they're going to be getting tetanus booster and sometimes even inject it around the area, depending on what it is. Chicken pox are very contagious, but it's 2 days prior to that rash when you don't know, and that's when they spread it. And they are contagious until all of those lesions are crusted over. If you have head lice, making sure we inspect the hair follicles, right? Making sure we comb it with a fine tooth comb and getting out all of those eggs in there. And we apply that stuff on them and mix shampoo and comb it and make sure that we do wash all the bedding on these children. Otitis media, one of the things that we can do to decrease occurrence of it is breastfeeding. That's the big one. But also the other one is nobody should be in the house smoking with these children. You need to go outside and smoke if you need to smoke, right? Because actually just smoke can cause ear infections in children. Attention deficit, hyperactivity, stimulating meds that we give, Adderall. If the kid's hyper, you give them something hyper and it actually calms them down. It just works opposite of what you think for sure. Now, a kid with ADHD, they're all over the place. They can't focus, they can't concentrate. So, organizational charts and be consistent with a schedule. These children coming to the hospital, we need to know their schedule so we can follow that routine, right? And so they don't get confused, one place should be designated homework area. All right, let's go into some infectious diseases. One of the things that we can see is low neutrophil counts. And low neutrophil counts are usually less than 1,000. If they get to 500, that means they have no immune system and can go into septic shock quickly. So if you've got a group of patients and one, no matter what their condition is, if they have a fever, low neutrophil count, that's your priority. Make them first, okay? Infection control in a hospital, always wash your hands. That's the big thing. And children and parents that are placed into respiratory isolation, let's say that meningitis, that bacterial meningitis, they can't come out and walk around. They can't spread, their infection to everybody. Make sure the parents know that. Immunosuppressed children of any type, whether it's a congenital heart, whether it is cystic fibrosis, sickle cell, if they have a low-grade fever of 100.5, they call the doctor. They need to start prophylactic antibiotics. They do not have an immune system that can handle it. They need help. So as soon as they can, they need to call the doctor and be placed on antibiotics. Giving immunizations to children, those 2, 4, 6 months, we give a lot of them, don't we? And one of the things is maybe 2 in each leg. It's a lot of stuff. What they say is when they get it, you take and pedal their legs, their knees, bend them up and down, and that moves the muscle and moves it. Whenever I get COVID or influenza shots, I'm taking my arm and I'm rolling it around and around and around. I never have pain because I have done this pedaling or bicycling, it's called too sometimes. Also, some of them get hot and painful. Put a cool pack on it and give them, depending on the age of the child, Tylenol or acetaminophen for the first 6 months. After 6 months, they can have ibuprofen, Motrin for that discomfort and maybe a low-grade fever, and that's normal. The body is building up an antibody and then can be absolutely take care of that disease if it ever gets introduced to them. Rheumatic fever, as I said, everything will go away, even the chorea by the strep throat. Only that good old heart valve will have to deal with it. Now, I have seen up to 4 questions on acid base. So I've given these little pictures here, but let me explain it very easily to you. If you're hyperventilating, your respiratory alkalosis, just like Kuzmal, respiratory alkalosis is trying to do opposite of what the body's in, that metabolic alkalosis, acidosis. Now, how do you remember diarrhea and vomiting and what they are? Well, think about vomiting. What are they vomiting? They're vomiting stomach acid. They're getting rid of acid. What is left? Metabolic alkalosis. When you're having diarrhea, all of those enzymes used for digestion are all alkaline. You're getting rid of alkaline like crazy. What is left? Metabolic acidosis, okay? So that's a good thing for you. One of the things I want to tell you, when you think you have the answer, go back and read the question to make sure you're answering what the question's asking for. And I know that's the most common thing that I see in getting wrong answers. So there's your review. I hope it helps you. I wish you all the best. I'll be following all your grades. So if you need anything, just let me know. Any of you can get a hold of me. If I'm not your teacher, I'm still your teacher, okay? You all have a great day.
Thank you.
Thank you.
Thank you.
Thank you.
You're welcome.
Thank you.
Thank you.